Good morning, how are you? Wish you are fine. I want to speak about the effect of botulinum toxin type B for hydradenitis suppurativa. In the American Journal of Clinical Dermatology, there were an abstract about the effect of botulinum toxin type B for hydradenitis suppurativa. It was a randomized double-blind placebo-controlled pilot study. The background was the botulinum toxin is a potent neurotoxin with a long history of therapeutic application in neurological and dermatological condition with a strong efficacy and safety profile. The objective their aim was to assess whether intradermal injection with Botox B type B is an effective treatment for hydradenitis suppurativa. The methods: 20 patients with hydradenitis suppurativa HS stage 1 to 3 disease according to Hurley's classification were consecutively included for treatment with either a placebo or Botox. At the next intervention after 3 months, all participants received the active substance and another follow-up at 6 months. The primary outcome was quality of life measured using the Dermatology Life Quality Index, while secondary outcomes were the visual and analog scale for pain in the breast, boil, and HS related impairment of general health, as well as changes in physician reported disease activity assessed as the number of total lesions and reported adverse effects of treatment. The result was improved from a median of 17 at baseline to 8 at 3 months in the Botox group, compared with a reduction from 13.5 to 11 in the placebo group. Improvement of the patient's own ratings of symptoms and a reduction in total lesions supplemented the primary outcome. 55% of the study population reported some degree of hyperhidrosis. The conclusion was Botox improves the quality of life in patients with hydradenitis suppurativa. Furthermore, comorbidity between HS and hyperhidrosis is suggested. In the abstract about the introduction, hydradenitis suppurativa is a chronic skin disease characterized by painful, deep-seated, inflamed nodules, abscess, and in the later stage, fistulas, sinus tracts, and scarring in apocrine glands. Because of that, I spoke about the anatomy of skin, bearing areas of the body. The understanding of the disease pathogenesis remains incomplete, and previously accepted models of HS pathogenesis are now being changed. Occlusion of the hair follicle is paramount in the manifestations of HS, but the instigating mechanism of occlusion is controversial. Subsequent inflammation and combined innate and adaptive immune dysregulation lead to the development of skin lesions in HS. HS has an estimated prevalence of 1 to 4%. The average age of onset of HS is in the early 20s. And substantial data suggests a female predominance with a 3:1 sex ratio, sometimes 5 to 6. Additionally, HS is a condition associated with considerably impaired quality of life, depression, and disability. HS is difficult to treat and clinical practice is variable. The treatment of mild and moderate disease includes topical and systemic antibiotic, intralesional corticosteroids and retinoids, and limited surgical option. Tumor necrosis factor inhibitors are a treatment option for moderate to severe disease stages, while surgery is an important treatment option in the late stages with fistulas, sinus formation, and scarring. Advice on lifestyle is crucial to prevent exacerbation of the disease. Botulinum toxin is a potent neurotoxin produced by the bacterium Clostridium botulinum. There are 7 different isoforms of it: Botox A, B, C, D, E, F, and G, with Botox A and B being commercially available. Botox blocks the release of acetylcholine and a number of other neurotransmitters from presynaptic vesicles, and has a long history of therapeutic application in neurological conditions with a strong efficacy and safety profile. Botox is used in a number of dermatological conditions such as hyperhidrosis, pruritic dermatosis, and acantholytic disorder. Botox has a weak effect on alpha motor neurons and muscle, with a ratio of 1 to 50 to 100 in favor of Botox A. Conversely, Botox B has an almost equipotent pseudomotor effect compared with Botox A. This discrepancy is in effect on muscles versus sweat glands makes Botox B most suitable in the treatment of larger body surfaces without the threat of causing muscle weakness. 5 patients have previously received Botox A injections for HS, the same disease, Hydradenitis suppurativa, with a positive outcome, whereas a study performed in 5 HS patients reported improvement in the dermatology life quality index, but not for the number of nodules or VAS for pain. The purpose of the current study was to evaluate the effect of Botox B in a randomized double-blind placebo-controlled settings with respect to the QOL, pain perception, and number of lesions in HS. Materials and methods. Trial overview and population. This was a single-center randomized double-blind trial performed in the outpatient clinical of the Department of Dermatology at the University Hospital of North Norway. The trial was conducted in accordance with the Declaration of Helsinki and monitored by good clinical practice units. The Regional Committee for Medical and Health Research Ethics in North Norway granted ethical approval, and all participants provided written informed consent prior to enrollment. This study was registered at clinicaltrials.gov. 20 patients with HS stage 1 to 3 disease according to Hurley's classification were consequently included for injections with either a placebo saline or Botox B. Neuroblock, Isel, Sweden. Key exclusion criteria were emergency medical or surgical treatment of HS, pregnancy, breastfeeding, and neuromuscular disease. Inclusion and exclusion criteria as well as a consolidated standard of reporting trials diagram are provided in the electronic supplementary material. Interventions, randomization, blinding, and study drugs. The principal investigator responsible for the evaluation was blinded throughout the entire study, and participants were blinded until the first evaluation at 3 months. Thereafter, all participants received a second injection procedure unblinded using Botox B. A secondary investigator was responsible for the injection with interventional substances. After using the randomization tool in the electronic data software tool, at baseline, the study participants randomized in a 1-to-1 ratio received either the active substance Botox or placebo. After 3 months, the blinded placebo-controlled setting was succeeded by an open setting in which the Botox B group received a second treatment with Botox B, and a former placebo group was injected with Botox B. At the two study group, B1 and B2 and B1 received 1 and 2 Botox treatments respectively. Were calculated differences in each group separately with the changes from baseline to the evaluation at 3 and 6 months treatment. One patient randomized to receive Botox at baseline dropped out before the 3 months visit due to a long travel distance to the study site. Botox was diluted to 50 units in normal saline by secondary investigator. Normal saline was used as a placebo. 0.05 to 0.1 ml of assigned solution was injected intradermally in a grid with 1 to 1.5 centimeter between each injection in the affected areas and in the pre-lesional healthy appearing skin, with a maximum of 1,300 units per injection session. The total dose per treatment area varied depending on the location of the disease, limited per field up to 150 unit armpit, 200 unit to the groin, and 60 unit in the perianal and perigenital areas. The maximum total dose allowed per treatment was 4,000 units of Botox B. Lesions in the other locations such as inframammary area, periareolar area, and abdominal fold were not assigned for intervention. Patients were offered topical anesthesia with lidocaine, prilocaine cream, EMLA, under occlusion with the plastic film 30 minutes prior to intervention. Confoundings of HS treatments such as antibiotics, local corticosteroid injections, isotretinoin, and azelaic acid were not allowed during the study. Trial outcomes. The primary objective of this study was to present QOL data in HS participants at baseline and 3 months after the Botox B injections versus placebo in a randomized double-blind manner. The primary outcome was the DLQI 19. Secondary objectives were to assess the pain from the worst boil, the participants' HS-related impairment of general health, the number of total lesions, nodules, abscesses, and fistulas, and the adverse effects at baseline and at a follow-up. 3 months post-injection Botox type B versus placebo. Secondary outcomes were the rating of pain in the worst boil on the visual analog scale, rating of the HS-related impairment of general health, VAS, on a VAS counts of total lesions, and a report of possible adverse effects of treatment. The outcomes were aligned with the recently developed core outcomes set for HS. The Nordic registry for HS was used for the registration of endpoints and baseline characteristics. In addition, all patients were investigated using the validated hyperhidrosis disease severity scale at baseline to evaluate an existing comorbidity. Statistical methods, descriptive statistics were used to compare the baseline characteristics of the trial participants. Continuous variables were summarized as appropriate using means with the standard deviations as a median with medians with minimum and maximum values. Categorical variables were expressed as frequencies. Efficacy analysis compared treatment arms at month 3 using a rank analysis of covariance combined with Mantel Hansel statistics with adjustment for the baseline value of the respective outcomes variable within group. Changes from baseline to 3 to 6 months were explored using graphical presentation and the Wilson assigned rank test. For all tests, the level of significance was set at p less than 0.05 due to the exploratory nature of this study. No adjustments for multiple comparisons were undertaken, and p-values should not be used to infer definitive treatment effects for secondary outcomes. All statistical analyses were performed using SAS software version. The results: the study population had an expected predominance of female participants, 17 of 20, current smokers, 13 of 20, and a high median body mass index. It was 32 kilogram on the M plus. 15% patient in the study population experienced severe hyperhidrosis, and 8 patients experienced mild to moderate hyperhidrosis. Participants' baseline characteristics. The primary outcome at 3 months improved from a median of 17, maximum 21, minimum 10 to 8, maximum 22, minimum 0. In the Botox B group, compared with an improvement from a median of 13.5, maximum 21, minimum 2 to 11, maximum 20, minimum 1 in the placebo group. The patients on rating of HS-related impairments of general health of the VAS from 1 to 10 improved in the Botox B group from a baseline median of 8, maximum 10, minimum 6 to post-treatment of 3.5, maximum 9, minimum 0, compared with a median of 6, maximum 10, minimum 2 to 5.5, maximum 10, minimum 1 in the placebo group. In addition, the number of total lesions and the experiences of pain measures on the VAS were reduced in the Botox B group, but the difference between groups were non-significant. A significant reduction in total lesions from baseline was seen in the B2 group at both 3 and 6 months. In the B1 group, no significant differences were obtained at follow-up in 3 months after placebo, but the number of total lesions improved after Botox B injections at follow-up in 6 months. That was all. So the results from patients in group B1 were who received one placebo and one injection treatment, and the B2 who received Botox in the 2 treatments, there were differences. Besides the changes in total lesions, improvement from baseline was also seen in the B2 group after 3 months in the terms of DLQI, which was P less than 0.05, HS-related impairment of general health and number of nodules, and 6 months in terms of DLQI, VAS for pain in the worst boil, number of nodules, and HS-related impairment of general health. As expected, no significant changes were seen regarding outcomes after placebo in the B1 group at the 3-month evaluation. Besides the reduction in total lesions, a tendency for improvement in the DLQ1 from a median of 13.5 at baseline to 6.5 VAS. HS-related impairment of general health and number of nodules was seen at the 6-month follow-up. No adverse effects were reported. One patient in the placebo group required surgery of a draining sinus during the intervention period. That was all about the study. I don't want to speak more about it. So in general, we should use Botox type B to which has a good effect on the on Hydradenitis suppurativa. That was all. Thank you for listening. You may feel that it is tough a little bit. Thank you for listening. Thank you.